if I could invite Dr. Selwyn Dexter up to for the next presentation. Just while he's coming up and getting his presentation ready, a couple of things struck me. It's very there's a lot of similarities between the work that we do in the group here and Keratoconus, Australia, and we've already started sort of thinking about some ideas that they've brought over as well. One of the most obvious ones is the DVD. So hopefully we're recording today's proceedings for DVD, and then we'll be making those available to those who weren't able to come. The other one was that made me think was when Matt was talking about fundraising issues. Now, in terms of all the work that we do, I mean, we can't do any of it without the support of our members, and through the generous support of our members and all the fundraising activities that we've been involved in, we've been able to effectively subsidise conferences like today's. So our members have been extremely generous, but we always need more funds to get on and move forward to produce publications. So we had a plea this morning for millions, but probably we could a bit less would be really helpful to us for us to continue doing this type of work. So if I hand over to Dr. Dexter.
Necessity is the mother of invention. I'm a general medical practitioner. I'm also a medical acupuncturist, having practiced it for about 20 years. Medical acupuncturist is the term used by the British Medical Acupuncture Society. It's a body who's trying to find a scientific basis for why acupuncture should work. Why I say necessity is the mother of invention, because my son Daniel was diagnosed with keratoconus at the age of 12. He probably had it a couple of years earlier, but as his dad was a doctor, nobody picked it up. And Daniel, is an emotional thing watching your child having visual difficulties and trying to put little bits of plastic into his eyes, which he couldn't tolerate. And I noticed, whilst he was having this tough time, that his eyes were very, very sticky, and he was sneezing a lot of atopic symptoms. And I know from acupuncture that acupuncture is a very good treatment for hay fever, sinusitis, for discharges or rhinorrhea, similar to the symptoms Daniel was having. So as I explained at the last time I spoke to you, I chased him around the house with my needles. I caught him once or twice only, but we did manage to stop his eye stickiness, and we managed to stop him sneezing. So there was a basis of something there which I thought worth pursuing. I approached the Keratoconus Society AGM, and they allowed me to speak at the last meeting 2 years ago about my thoughts on acupuncture, and some patients bravely came forward, and I've been looking after them the last year or two. A little bit about acupuncture, but not too much, because it's about acupuncture in keratoconus that I want to speak about, is that, first of all, acupuncture is medicine. It's not alternative medicine, it's not complementary medicine. It's as pragmatic as taking a pill, having laser treatment, or having surgery. Right. With acupuncture, do you base your treatment and research on theories which are over 3,000 years old, which remain largely unchanged and fixed? Or do you base it on information which is 50 years old and reviewed every 5 to 10 years by scientists and your peers, trying to establish a basis for why it should work? These are some of the general effects of acupuncture. Endorphin release, a well-known one. It's one of the first things I realized about 40 years ago. Also these other chemicals. Local effects, afferent nerve stimulation can release these peptides, vasointestinal peptide, calcitonin G related peptide. I think it's about 30 chemicals that have been identified. It also obviously has effects on the nervous system. from a medical point of view, acupuncture analgesia is the one most well known. I think when President Nixon was in America, in China in 1973, I think one of these reporters developed appendicitis, and his appendix was taken out under acupuncture analgesia, and this caught the world press. And they sort of rapidly worked out how it should work. It's blocked by naloxone, which is an opiate antagonist, and it's not blocked by dextronaloxone, which suggests that only certain forms of naloxone are effective, implying that it's a very specific method of action. And as you see, it's coming down further down the slide here. If you block certain pathways in the brain, you can prevent the analgesia. So acupuncture has a very specific effect. I work in a pain clinic partly in the Royal Free, and we see a lot of chronic pain. And pain is physiologically and pharmacologically very complex, and acupuncture can be very effective. We've seen patients from Moorfields who've been referred there with eye pain after operations, and it's also effective. So on that basis, I thought it a reasonable thing, and I thank again the Keratoconus Society and the patients who volunteered to do a little trial of acupuncture and keratoconus symptoms. As I say, when I presented this, when I made a plea for patients at the last meeting, I've seen about 9 patients, which I'm going to present now. Very important, can it do any harm? Generally speaking, acupuncture is harmless. The main side effect, it causes feelings of relaxation, and most patients find it quite pleasant. It's generally not painful. It can cause bruising. The needles are very, very fine. Whilst you don't attempt to put them anywhere you shouldn't, even if you did, you're unlikely to do much harm. Although you have to be careful you don't puncture any lungs. But with keratoconus patients, we don't go anywhere near there anyway, so that's not going to be a problem. Also, I spoke to a colleague from the British Medical Acupuncture Society about keratoconus, and he suggested I should treat my patients vigorously. But in fact, I didn't, because sometimes with acupuncture, like when you're treating migraine, you can induce a migraine before you cure it. And I didn't want to induce any worsening of the keratoconus symptoms. So I went gently. So where do you put the needles? Again, I didn't use many needles, and the needles varied a little bit from patient to patient, but I did use 2 main points. Sorry, it's not a very good photograph. Actually, I must thank John Smith. John Smith made a much better PowerPoint presentation than I did, but it was so fancy I couldn't use it because it would put me off my speech. but he made the needles come out much better than that. But acupuncture points are all on very well identified anatomical sites. Like this point here is a well-known point. It's on the large intestine meridian, or LI4. That's a World Health Organization definition. The Chinese call it Hoku, but it's on the actual point is in this case is between when you oppose the thumb to the forefinger, it's at the top of the crease in the hand, and that's where that needle went. And the reason why I use this point is that this is a very good point for hay fever, for sinusitis, for allergy, and some of these symptoms of keratoconus, so it seemed logical to use that one. And then here's another point. This is also another famous point. Again, John's slide was much better. This is liver 3. It's on the liver meridian, and this point is in between the first and second metatarsal heads, which are bones in the toes, in the feet. And I chose this point for 2 reasons. One, it's a sort of King's Cross point. It's often used in many conditions anyway, but it's also, going back to Chinese tradition, it's a point used for collagen, for acting on collagen. The cornea is collagen, so again, it seemed a logical point to use. Now, the next slide, this is going to be a summary of the work that I did, 9 patients. I'm sorry, it's a horrible slide, but it's the main slide of the whole lecture, or talk, really. There's only one like this, so you'd be pleased to know, right? So I'm going to try and talk you through it a little bit. I hope most of you can see that. Basically, we had 9 patients, and that goes down the far column. I'll just show you over here. 9 patients. And I haven't put the gender or the age of the patients in because I didn't want anybody to identify them, because most of them came from the society. And this is the number of years they've had keratoconus, from 20 years at the top to 12 years at the bottom. I'm sorry if it's not clear to some people. The third column shows the number of acupuncture treatments they've had. Okay? Now if I can just go back to the top patient, the first patient, he had keratoconus for 20 years. He had 7 acupuncture treatments in a 7-month period. Now the benefits that he volunteered through this treatment was that his contact lens wearing time increased. See at the end, and although this chap wore his lenses quite a long time anyway, he used to wear them till about 10 p.m. at night, he found he could wear them until 3 a.m. in the morning when he went to conferences. He found his contact lens discomfort was down, the stickiness and mucus produced at various times, his eyes were down, the eyes were less itchy, and other people, not him, commented that he had less, sorry, hello? Yeah. Other people, not him, commented that he had less, his eyes were whiter. I'll come along to side effects in a minute. The second patient, keratoconus 4 years, 4 treatments. For some reason I haven't recorded the treatment period, but it would have been about 3 or 4 months, I would have thought. The contact lens wearing time increased, contact lens discomfort decreased, eye irritation better. Significant, because I'll come to that later, more tear production. The third one, 30 years history keratoconus, 10 treatments in 12 months, contact lens discomfort down. Some of this might mean less lid discomfort as well as corneal discomfort, but I haven't broken that down in this slide here. Less stickiness, less itchy eye, less painful eye. Number 4, keratoconus for 16 years, 7 treatments. I've mentioned there's something about a stud, which is very important, but I'll come to that later. 6-month treatment period. Okay, I don't want to teach you to suck eggs, but contact lens wearing time increased, lens discomfort down. Number 5, interesting patient. 3 treatments for over 1 month only, no improvement at all. It may or may not be significant, but this particular patient had a condition called Sjögren's syndrome, which is a drying out of mucosal linings, dry eyes, dry mouth, other areas can be very, very dry. And that might be important, or it might just be a coincidence. Patient number 5, 28 years of keratoconus, 3 treatments in 1 month only. Again, no, that's the one about, sorry, I'm losing my place. Patient number 6, I want to come to patient number 6 later because it's quite important. And then these other patients here, 4 treatments over 2 months, 3 over 2 months, 3 over 2 months. Well, again, positive symptoms of contact lens wearing time, less stickiness, more tear production. The last patient I've included, but I put a bit of a question mark because the treatment was interrupted. Now, I just want to go back to patient number 6. Now, could you hear me? I'm sorry if... Hello? No, sorry. Now, patient number 6, the patients were coming, some of them from reasonably far distances, and it's quite difficult to come every 4 weeks or 6 weeks, whatever it was happening. And I thought, wouldn't it be a good thing if the patients could treat themselves? Now, I'm sorry, this is a very bad picture, which I took myself, so sorry about that. But you can just see a little white area on the foot. That is a stud. It's an acupuncture stud. And what an acupuncture stud is, a tiny 2mm needle with a little plaster, which the patient can insert himself, or the therapist can insert. And the advantage of it is you can put it in, and you can leave it in for 2, 3 days, 4 days, 5 days. So you get a long stimulus. And so what I did with this stud, I thought it would be a good idea if I get patients to use this stud for 2 reasons. One, they could put it in themselves. And secondly, I wouldn't have to do the work. Now, what happened was, with this particular patient, what I got her to do, I got her to put 1 stud in her foot, starting in her right foot, which she left in for 3 days. She took it out, then a week later, she put a stud in her right hand, and the same points where I put the needles. A week later, she did the same for the left hand, and then a week later, only 3 days for the left foot. So one stud for 3 days per week, which a patient puts in themselves. So it's quite simple. So I want to go back now to lady number 6. This is the lady. This patient had 2 treatments. She had a graft in her left eye. So she had 2 treatments just of studs over a 2-month period. Again, her contact lens wearing time went down. Her contact lens discomfort went down. Less stickiness, less eye pain, increased tear production. In fact, she phoned me up to where I phoned her, and she said she'd stopped using the stud because she noticed large tears coming from her right eye. I told her to start using it again, but she told me, when asking her how she felt, she said that for the first time in many years, and she had this condition for 40 years, her eye, I think she was referring to her non-grafted eye mostly, was feeling more normal and not as bulgy as she described the sensation the eye often had with the keratoconus. I did use the studs in 2 other patients. In patient number 4, where there was no apparent effect at all. And again, it appeared to have effect in this last patient, although I can't say because the treatment was interrupted. So that's a summary. 8 patients, some degree of benefit. 1 patient, no benefit. This is the patient who had this dryness of the mucosal membranes. I mean, I haven't sort of been brought up as a scientist and a medical scientist, and when you see, 8 patients out of 9 getting benefit, you tend not to believe it because it doesn't sound very realistic. But I can just report what the patients said, and there was benefit to some degree in these patients. Again, the Sjögren's syndrome may or may not give an indication as to what is happening. Dryness of the membranes, removing the benefit of any acupuncture treatment, possibly, don't know. How does acupuncture work? Well, it's a bit of a broad statement. A fundamental effect on a system with a particular effect on parts of that system that contribute to keratoconus. It doesn't really mean anything like that, really, but it's a general effect, perhaps with a specific effect on keratoconus as a side effect. Does it work by an anti-inflammatory effect? Less stickiness, the eyes less red, implies less vascular involvement, less blood vessel involvement. I was impressed by the patient's, well, I wasn't so impressed. Patient said, three patients had increased tear flow. The lady who said that the eye was less bulgy. I spoke to one consultant ophthalmologist who told me that the quality of a keratoconus cornea is of a very boggy quality. So is there some fluid transfer process being influenced? So is it effect on tear flow, tear quality? Don't know. Just a thought. So where do we go from here? Well, that's the obvious thing. Got to repeat. I mean, have to repeat the experiment. See more patients. Perhaps see more, get a larger group of patients. It would also be useful, perhaps, to speak to or get some feedback from professional people as to what objective thing we could measure to go alongside as to why acupuncture should work. Right, and thank you. Right? I've got to thank, first of all, I want to thank John Smith again because he made this beautiful PowerPoint presentation, much better than my one, and it was all beautiful red circles and all sorts of things in it, but it would have put me off, so I didn't use it, and so mine was a bit more simple. But I also want to thank the patients, the keratoconus group and the keratoconus patients, because a famous teacher once said, I learned a lot from my books, more from my teachers, but most from my students. And this applies here in a sort of way, in that whilst I've done a lot of work with this project, what I learned from the patients had a direct impact on the quality of my son's life, and I have to thank you for that. My son, as I said, he was 12, he was diagnosed, and he was really having a tough time with his... He couldn't tolerate gas-permeable lenses, he couldn't tolerate scleral lenses, and his schoolwork was going like that. And the only way he could see was by squinting, and he didn't like to squint because his friends could see. So he was a top-grade student, but his work was going like that. And one of the patients who kindly helped me with this trial told me that he had some similar problem with the contact lenses, and he recommended a contact lens practitioner who he thought might be able to help. So I went to see this guy, who had good confidence, gave my son confidence, and he fitted him up with a piggyback lens in his left eye, which was the good eye. And that was November. That was the November of his GCSE year. And then he put in a sprint, and with a bit of coercion and bribes from his mother, he got a very good set of GCSEs. He then, following his GCSE results success, he went on a camping holiday in Israel with some friends. And whilst camping, with his piggyback lens, he didn't know he'd put not one, but two soft lenses in his good eye. And due to the reduced oxygenation, he got infection, he got an ulceration, and he ended up in the Hadassah Hospital in the corneal unit in Jerusalem for 3 days. But he fortunately got better there. I think this was possibly due to the fact that I believe apparently most of the corneal consultants there appear to be ex-Moorfield people. But two significant things happened as a result of this trauma in Israel. When he was in hospital, he was in the next bed. In the next bed was an Ethiopian, a visually impaired Ethiopian who spoke Arabic, who somehow taught him backgammon. And the other thing which transpired was that he had to have a corneal graft, because his right eye only had finger vision, and with his left eye compromised, he couldn't see the food on his plate at that time, whilst he was in the hospital, although his left eye got better. When I was in England, anyway, a friend of mine in England was a doctor who's also got keratoconus and had a graft. He had a full thickness graft. He said to me, try and get a partial thickness graft because less problem and less side effects, especially in your son as he's so young. So I went to see a very highly recommended, very nice ophthalmologist in London, and he took one look at Daniel's eye and said that partial deep lamellar graft is out of the question. It's technically too difficult. At this point, we were a bit down at that, but we accepted that. And then I started to look at, as a father would do probably, just to try and get the edge, look at some non-surgical treatments, like I think it was earlier mentioned, Intex. And again, through a member of one of the patients who had helped me, she gave me some information about an ophthalmologist who was doing work with stem cells and Intex. So I ended up seeing this ophthalmologist for a second opinion. And he took one look at Daniel and said, Intex are no good. The cone's too steep. So my wife said, well, what should we do? And he said, a deep lamellar graft. So we were a bit confused, and my wife said, well, such and such person said that wasn't possible. And this guy said that he thought it was possible and that he'd done technically more difficult ones than Daniel. And so we went ahead. Last October, Daniel had the deep lamellar graft. Before the operation, he had finger movement. A day later, he could see 2 lines on the chart. And now he's 6'9", I believe, in the eye, and he's actually having driving lessons now. So I think the Keratoconus Society is a fantastic society. The networking and the information that you give to each other. I know a couple of people who won't join the society, though they've got keratoconus, because they think it labels them. But I'm going to encourage them to do so, and thank you all very much. Thank you.
Thank you very much indeed, Dr. Dexter.